Thank you. Thank you. Can you hear me?
Yeah.
Is this okay? These things are always too tall for me, so I'm just going to put my notes down here so I'll stay on track. And I know you're all ready for that 3 o'clock and your certificates. But it's good to be here this afternoon and talk about ethics in palliative care. First, let me try to define, well, all of you know what ethics is, and you've had it all day long in one form or another. Palliative care, sometimes palliative care. It's simply caring without curing. And patients who are who have a sickness that we cannot cure then are comforted and are well cared for. The symptoms are controlled, such as in hospice at the end of life. But we also have you have diseases that go on for a long period of time, of which we can simply palliate or take care of symptoms. And of course, one of those is diabetes. You can't cure diabetes, so the treatment of diabetes is really palliative care for a long period of time. But as we go along, please feel free to ask a question. Let's make this an interchange, and if something isn't clear, we'll just go and take time for that. Now, this is a long outline, and the reason that I do a note-taking outline instead of slides is that you can jot down a few things and take them with you. The first 3 pages we're going to go over quickly because you have, yeah? Oh, yes, there's several in there. Sure. Well, if there's some who have not gotten them, please. Okay. You have touched on many of these things today. So the first 3 pages we'll go over quickly, please. If it's too quick, just raise your hand and we'll go over some of those points. But I want to spend time on page 4, which are the practical applications of the first 3 pages. In order to give page 4 a base or a foundation, I thought we'd start with just a review of basic ethical principles. Did you need more? There are a few others. I should put these in 3 stacks here, and one here. Anybody else need some of these? Okay, here we go, 3 stacks. Have you had a review of basic ethics? I know it's been talked about all day. I want to tell you my greatest resource book is this small book that is, it's written here under B, Steps in Clinical Ethical Decision Making by Johnson, Siegler, and Winslade. It's in our library. It's also in the bookstore. This is the 3rd edition. There are many books on ethics, some of them very difficult to understand, some of them very vague. But if you want a straight answer to your question, this book will give it to you. It's well done. So I follow along with that, some of the things in that book because they are so clearly defined. First, the basic ethical principles that we use every day. You've all heard of the beneficence, the non-maleficence, autonomy, truth, and justice. And beneficence simply means do good, and non-maleficence is avoid harm. And then we have the principle of autonomy, which frequently conflicts with the do good and avoid harm, because the principle of autonomy is simply a person's right to self-determination, and was articulated very well by John Stuart Mill, who said, over his own body and mind, an individual is sovereign. And then in 1914, Justice Cardozo of our Supreme Court said, every human being of adult years and of sound mind has a right to determine what shall be done with his body. Truth, the principle of truth. Now, you might say one thing, autonomy is never absolute. It's not 100%. A person cannot exercise that right at the expense of someone else if it harms other people. The principle of truth I put in here because you've heard beautiful description now, just in the preceding presentation, on informed consent. The principle of truth is behind our informed consent principles. And you have seen how very difficult it is to truly inform someone of all the things that can happen. It's impossible. We would have to have consent forms that stretch around the world. Truly informed consent is an impossibility. And it leaves, sometimes it makes our work much more difficult. And of course gives the court something to worry about. And the principle of justice, the allocation of scarce resources, or treating patients unnecessarily. We're not going to dwell upon those. I simply want to put it here as kind of a foundation to understand the other things that we'll be talking about. Now, thanks to Johnson, Siegler, and Winslade, I found a clear approach to clinical decision making. Many people shy away from ethics or ethical decision making because they feel that things are too vague and slippery, and they feel they don't have the expertise to handle it, that it should be handled by somebody who's an expert in this. But that's not true. We're each and every one, we're capable of making an ethical decision if we follow certain steps. And it has helped me in many severe problems to follow these steps. The 4 steps that are very well outlined in this little book are: what is the medical intervention? What are the patient preferences? What's the quality of life? And what are the other features, the contextual features, the surrounding features? So let's just go over that quickly and take the example of the decision whether or not to put in a feeding tube. Look at a concrete situation. Shall we or shall we not use a feeding tube in this patient? So you look at, what's the diagnosis, prognosis of illness? Is this a lady with Alzheimer's? Is this a person who has just had serious surgery and can't eat or drink right now, but has the potential to overcome this if we feed this person? Makes a big difference. What's the diagnosis here? Then, of course, we need to know all the medical facts. We need a good history, good physical exam. We need to know the details of this procedure that we're contemplating. Is this tube going to be just in the nose, or is it going to be placed surgically in the stomach? It makes a big difference as to whether or not this patient can tolerate it. Is this patient 90 years old and somewhat uncooperative? And if we put in a tube, is she going to be pulling it out? Do we have to put restraints on this patient? That all goes into the details of the procedure. Makes a big difference in whether or not we're going to use a feeding tube. And then, what exactly are we doing, and what's the probable outcome? Is this an Alzheimer's patient that's at end stage, that can no longer eat or drink, and the probable outcome is simply to increase, perhaps prolong life, but not to add to its quality? And what is the danger, too, of this treatment causing worse things, like aspiration pneumonia, which feeding tubes often cause? Those of you who handle them a lot know that the big danger in a feeding tube is the aspiration pneumonia that follows it. So, looking at all those things, trying to get a handle on exactly what we're going to do. Sometimes when we contemplate using a tube, I have found it useful to put a time limit on that. And if you're down to the wire and you really can't make up your mind whether or not to use that tube, and the family can't make up their mind, you might say, well, let's try it for 2 months, 3 months. If your mother is better and she has a good quality of life, then we can go ahead and remove it. But if after 2 or 3 months she's worse or she's no better, then let's go ahead and take the tube. It seems that once a tube is in, it's so hard for family to let go. You know, there's the decision to put that tube in is not as difficult as the decision to remove the tube or to quit using it. That's always because people feel that they are the agent of death for this person by withdrawing treatment. So if you're not sure the tube is going to do any good, suggest a time interval and say, all right, let's try it. 2 months, 3 months. If we get no good results, all right, then we know that this person's life will not be a quality life, and even though we prolong the life, perhaps this is not the way it should be. And that's a lot easier then to withdraw that treatment. Now let's look at some of the other things. What are the patient preferences? Obviously, if you're going to look at a tube, if this patient is competent and conscious, it's the patient's decision. And we go into, is the patient competent or incompetent? And these are legal terms. I think medically and in a more correct terminology, it's better to say, is the patient mentally capable or incapable of making a decision? Instead of competent or incompetent, and actually competency has to be decided by a judge in a court. But mental capability can be decided by anybody. You can certify, often you have the physician certify, is this person mentally capable? And you all know the 3 points in determining mental capacity. First, can the patient understand the information? Second, can the patient make a choice and see the consequences? And third, can the patient communicate to you that choice? Now sometimes, as you know, a patient can be mentally capable in the morning and not mentally capable in the afternoon. And that happens a lot in nursing homes because people go back and forth with their capability. So if you're going to ask somebody about a feeding tube, you might have to sample a little bit of the morning, a little bit of the afternoon, because you might get 2 different pictures on that patient. So, can the patient understand the information? Can the patient make a choice and see the consequences? And can the patient communicate the choice? Doesn't mean verbally. Sometimes if patients can no longer speak, you can have, say, you know, if you agree with me, raise your hand. Doesn't have to be a statement in words. Now, advance directives, I know that all of you are very familiar with them, and we're not going to spend any time on that. In the state of Texas, we have the living will and the durable power of attorney, which are all based on the Texas Natural Death Act, which was legislated in the 1970s and has had 2 amendments and is about to have another one. So they go on, clarify that. But that's what's behind those documents. And in 1993, they tried to clarify this further by the Consent to Medical Treatment Act, which is very familiar to everybody who has nursing home patients, because it spells out in greater detail how the surrogates, which have their power under the Texas Natural Death Act, how the surrogates can determine what the wishes of an incompetent patient are and give the orders. For example, the spouse, the majority of the adult children, so on down the line. And it makes it much easier for people, administrators and nurses in nursing homes, to determine the status of an incompetent patient. Any questions on that? And you all know that under the Texas Natural Death Act, surrogates can make those decisions legally for an incompetent patient. Now, one thing when we talk about surrogates, one factor that's sometimes forgotten is that the choices that the surrogates make should be aimed at improving the patient's well-being as defined by the patient. And how many of you have seen instances where the family is at odds, and this side of the family wants a feeding tube and this side of a family doesn't want a feeding tube? And it seems that the patient is the battleground between these siblings, and they're really each trying to exert their influence and their power, and they're not necessarily looking at what the patient would want. And I think if you can bring it around to, what does this patient want? What has she indicated? Has she ever said anything? Well, maybe sometimes they haven't. But look at it in terms of what the patient would want, and then perhaps the sides can come together. because this is causes a great deal of conflict at the bedside. So, the advance directives are good things. Unfortunately, they're not perfect, and one of the imperfections is they're not always on the scene. You don't have your advance directive with you when you're driving around. They're often not followed, because when a patient becomes incompetent, it's very easy for the family to say, do everything, doctor, and the doctor is going to do everything because the incompetent patient can't sue, but the family can. And when this happens all the time, it's not legal, and I don't know that any court case on that has ever come up, but that does happen, unfortunately. And then an advance directive could be misinterpreted. Some people have been allowed to die when they could have been saved because somebody is waving an advance directive. Oh no, doctor, you can't put that tube down. You can't do that CPR because he said here in this living will he doesn't want that. And perhaps this patient simply has a temporary situation and could get over it. That's scary. Then advance directives can't cover every situation. There's some situations that they simply do not refer to. And sometimes, unfortunately, a patient that has a DNR order, do not resuscitate order, receives less than maximum care. Sometimes healthcare workers regard that patient who is do not resuscitate as not requiring the amount of care that a patient with a full code requires, and that goes on. So we have some problems with advance directives, but all in all, they're a step in the right direction. Now, I'm not going to spend any time on what is the quality of life because you had, I'm sure, a beautiful presentation from Dr. Jensen in which you discussed the quality of life. There are subjective and there are objective features of this, and you can read here, one of the determinants is, can the fundamental goals of medicine be carried out? Can we improve this patient? Can we relieve pain? Can we restore function? And then a good way to determine the quality of life is our Karnofsky scale, to see if a patient is able to do certain things or unable to do them. And going on to value judgments, good, moderate, minimal, less than minimal quality. In general, the patients with persistent vegetative state have a less than minimal quality of life. You know, the PVS, persistent vegetative state patient, who is awake but not aware, eyes open, follows people, but are cognitively dead. And that patient has been described and is regarded in Texas as a patient who is terminally ill. The patient in a persistent vegetative state is regarded as a terminally ill patient in Texas, and food and fluids can be legally withdrawn from that patient. Now that's a real tough one because there are thousands of people, I don't know how many, there are thousands of people in the persistent vegetative state. And you know the problems that arise there. Patients can be in this state for years with tubes, and family comes to visit every day, and if one were to say, well, this patient really is terminally ill and we should withdraw food and fluids, you know what a storm that might cause. But legally, they are terminally ill patients from whom food and fluids can be withdrawn.
Can the family make a decision on this?
Pardon?
Can the family make a decision
Yes.
on this?
Yes, they
Even
can.
if the states
Yes, they can make that decision. They can make that decision. There is nothing illegal about it. If in the order of the surrogate order, if the next of kin makes that decision, that's legal. Yes. It seems, I don't think everybody is aware of that can be done.
Other states don't have that?
I don't know. The states vary on their determination of who is terminally ill. I don't think every state classifies the persistent vegetative state as terminal illness. I wish I had more information for you on that. But I know in Texas it is. It is classified as terminal illness. Any questions?
Is that a relatively new law?
Pardon?
Is that a relatively new
No,
law?
that was in the last amendment to the Texas Natural, well, yeah, relatively. Texas Natural Death Act, when was the last amendment? There was one in 79 and sometime in the 80s. So it is relatively new. Okay. I might mention that just recently we had an, let's see if I have this. They had an interesting court case in Massachusetts in which Dr. Kassem, who incidentally has spoken here several times, Dr. Kassem and Dr. Deck were sued by the mother of, by the daughter of a brain-damaged and comatose patient who was on a ventilator. The physicians determined that yes, indeed, that withholding therapy, that they could withhold treatment from this lady, and that all medical treatment was futile, and the daughter brought it to court, said the mother should have stayed on life support even though there was no benefit. The court then decided that the doctors were correct in taking the patient off the ventilator, and that since there was nothing that medicine had to offer this patient, that they could do so legally. And that is of course, one of the cases that have come recently about the futility of treatment. So you see, we're getting deeper and deeper into this withholding and withdrawing. This is one of the few court cases that has established that.
Is there any legal time span that the patient would have to be in this persistent vegetative state to make this a,
Good question. Generally, no, there's nothing legal, nothing in the law that says that. But generally, neurologists who make that final determination allow at least 6 months, and often they go as far as a year. And in adults, in children, it may be different. In children, the time intervals may change. But there's nothing in the law that specifies a time interval. But they're very careful about making that pronouncement. And that's not the same as brain death. That's not the same, because there is brain activity in persistent vegetative state. Because you can just, nobody thinks anything of withholding or withdrawing treatment from a patient who's brain dead. But persistent vegetative state has electrical activity of the brain. And they're very much, they have the cortical activity. Now, the fourth one, what are the other circumstances? I think that fourth point is usually if you've established if you've answered the other questions, usually you get your answer with 1, 2, and 3 here. But perhaps this is a difficult case, and there might be other features. So that's when number 4 enters in. And it enters in particularly when you have these problems with making a decision. First, you don't know whether or not the goals of medicine can be carried out. You don't know whether or not you can improve that patient. I don't have that on your handout. But also, perhaps you don't know the preferences of the patient. That this is a patient who's totally unknown. Nobody knows what that patient would want. The incompetent patient, of course. And then, when the quality of life is minimal or below. This is one of the things you look at, persistent vegetative state, quality of life less than minimal. And a big factor that sometimes makes the decision for you in this case, is this burdensome to others? Is this keeping a patient alive so burdensome to others that it must be relieved? And that can happen. That the burden of keeping the person alive may not be to the patient, but to others, to a family who's perhaps becoming impoverished because they're paying thousands of dollars, and children can't go to college because this person who's incompetent and who's hopelessly ill I don't mean anybody that can be reversed. I mean hopelessly ill person is being kept alive by technology. I had a patient, a mother and daughter, come to me years ago whose father and husband was on a ventilator, had had a massive stroke, 3 months on the ventilator, had made no progress whatsoever, was not comatose, but just in and out, was not persistent vegetative, but obviously not changing in any way, artificial everything. And they'd asked the pulmonologist, please take him off, and there had been no advance directives, so the doctor said, no, I can't do that. And they came to me, and I was so struck by their anguish. They came in and said, we go to see him all the time, and there he is, and I don't think he knows us, but we say hello to him, and said, we're dying. We're literally dying. Mother and daughter, we just can't take it anymore. We are dying. We know he would want to go, and to see him like this is just hurting us. And we went into a discussion for actually weeks before that could be resolved. And first I explored their feelings, and yes, indeed, they were in anguish. It isn't that they wanted him out of the way. They were anguished that their loved one was suffering in some way. And then we even called the pulmonologist in and said, doctor, what do you think? And he gave his reasons why he didn't feel he could do that. And we finally got down to his real reason was it was against his conscience. He agreed that there was no hope of meaningful life for this man. But then we got down to the bottom line for him, which was, I just can't do it. I can't square it with my conscience. We went on, we talked and we talked. It took weeks of dialogue. He finally agreed to take the man off the respirator. He did. The man died. And God bless this doctor. He went to the funeral and actually told the wife and daughter, he said, I should have done this a long time ago. He was big enough to say that. But he had struggled within his own soul. It was really a struggle to see, because he was honest and above board about everything that he thought. And so we were able to get right down to the bottom line, was I can't square this with my conscience. I just can't pull the plug on him. And then when he saw how much suffering there was, how much keeping this man alive was burdening the family who needed to get on with their life, then he said, well, let's do it. And he said to them, he said afterwards, we should have done this a long time ago. So these are the contextual features. These are the other things that enter into decision making. So you see, if you can go about it in kind of a logical way, 1, 2, 3, 4, maybe even writing things down on a piece of paper, decisions are much better to come by. And what's behind all this, of course, is good communication. People talking. People talking. You can't do it if people don't talk together. Because I learned a lot about this case. I learned a lot about the doctor's feelings and his struggle with his code of ethics. And I learned a lot about the suffering that happens in families that have to watch a loved one suffer. So keeping communication alive, talking, will help us decide these very important things. Now, I have something here about, I think, where are we on this one? I have a little different one here, because I always change things around. Are there any questions about any of that? Does that help? I think kind of give you some guideline, some direction for help in clinical decision making. Well, let's look at the practical applications. And first, and I'm not going to say much about this, are the ethical aspects of pain control, which all that means is that we're finding out more and more how to control pain well. We know how to do it now. We can control pain in all instances. Now, sometimes in the rare instance, it requires heavy sedation, but we can control pain in all instances. Many physicians are not doing it yet, even though the knowledge is out there. We have guidelines the government has issued. We have knowledge now concerning this. We have books on it. For a physician not to control pain, I think, is not ethical and is immoral. And I see in work in hospice, we give a great deal of narcotics and opioids for severe pain. We have to use them. In order to give that here in Texas, we need a special prescription form called a triplicate. That's burdensome to fill out. Some doctors will not fill them out, won't even have them in their office. For what reason, I don't know. Maybe they feel the feds are going to be looking over their shoulder. But a number of physicians will say, well, I can't give you this because I don't have the triplicate form to write it. Or they may say, you might become addicted to this morphine. And there is no reason for that because people, when that's given properly, patients do not become addicted to morphine. But the other point in dealing with the ethical aspects of pain relief is that we have to remember the double effect of medication. And I think this is important for all nurses that give opioids, sometimes in large doses. When morphine or another opioid is given for the control of pain, it may also have, in a very debilitated patient close to the end of life, it may also have the effect of perhaps shortening that patient's life by usually by a few hours, not by days or months, anything like that. But it can, in a patient who's very close to death, perhaps shorten life for a few hours. That's a very scary feeling for some people. I've killed that person. And they feel guilty. And you know, nurses often hate to give that shot because I don't want this patient to die on me. So this double effect is something that we need to remember happens when we give medication for the control of pain. But what is important here is the intention. When you give that dose of morphine, you do not intend to kill the patient. You're giving it for the control of pain. Perhaps this other is an unintended effect, but it is not euthanasia, it's not assisted suicide, it is none of those things. It is still you're administering medication for a truly a medical cause that is truly beneficial for that patient. And your intention here is what's important. It is the intention that makes all the difference. A few patients, perhaps I might say that here because I want to bring out the point that the rare patient that cannot get pain control with our ordinary methods or control of other symptoms, not necessarily pain, might have to be sedated to the point of unconsciousness. I had such a patient recently, and I had to really go within myself. It was a man who was very, very short of breath. He was not in so much pain as he had shortness of breath such as I have never seen before. We could not relieve it with oxygen. We could not relieve it with anything that we did for this man. He was very, very alert and begging. He really asked for physician-assisted suicide, but not fully, because he was Jewish, and this is against the Jewish tradition and the Jewish belief. So he didn't come right out and say, "Hey, kill me," but that was really on his mind. He said, "I can't stand this anymore. I can't. I want to die." So we went on for a while with ordinary treatment, and it was no use. Went daily. He was on hospice for 10 days. We went daily, and we were impressed by his terrible, terrible suffering. And during that time, he was coming to terms with the fact that he was dying. He had really had a very recent diagnosis, and things had progressed very rapidly. So he had not really a chance to feel what his attitude was toward death. And he was processing a great deal, particularly his relationship to his family. At first, all we heard was, "I can't go to work anymore." He had been at his desk every day, even during his chemotherapy. "I can't go to work anymore, I'm no good." And he had this wonderful, loving family. In fact, during this period of time, a grandchild was born. And the family was all around. They came from all multiple places in the United States. And they were so caring, so loving. And actually, during the process of anguish, he began to understand what it was like to have a loving family. And perhaps before he knew it, but he lived for his work. And you know, there are many people like that. But now it was a family. And he began to spend time with them and bless them and give them words of wisdom and do what is common for good Jewish people, an ethical will, in which they tell people about what they expect of them after they're gone. But during all this time, he was still in horrible, horrible anguish. So as we were working through this, he finally said, I can't. He said, I can't. I'm ready to die. So I asked him, he was fully alert, fully conscious, would you like me to give you enough sedation to render you unconscious until you die? And he said yes. He was fully aware, the family was fully aware, and we did, and he died. Now, that may seem like physician-assisted suicide, but it was not, because my intention and the intention of all of us who dealt with him was to relieve his misery, to relieve his shortness of breath, and the only way to do it was to render him unconscious. We agonized. Believe me, I didn't sleep several nights because this was a very difficult decision to make. But he made the decision, the family made the decision, and he died a peaceful death. But these things can take a great deal out of you. And you have to remember that what you are doing is the intention. You are not intending to kill the patient. I mean, it may seem like a very fine line, but the intention is to relieve the suffering. Whether it's with morphine or whether it's what we had to give this man was sedatives to render him unconscious, it doesn't matter which medication it is. The intention is to relieve the suffering. Now, fortunately, there are just a few. These cases are rare. It's a good thing, because I think in all my years in hospice, 17 years in hospice, I have not encountered, I think, less than 5, which is a good thing. So we don't see that every day, but you might, when you hear the people who are pro-euthanasia and pro-physician-assisted suicide, you might think that happens all the time, but it doesn't. It doesn't, because pain can be readily controlled and alertness preserved with the methods that we have now. So that's, I think, where time is drawing to a close. I'm not going to say much about do not resuscitate, except that when a doctor, that's a doctor's order. When a doctor writes it, they should establish in the progress note why they are writing it. All of you in nursing homes, I know, would like to see that done, right? They need to write a note. I discussed this with either the patient or the family. I consider this case hopeless, and I hereby give a do not resuscitate order. A simple statement like that, perhaps naming the people of the discussion. The nursing homes are making it very easy for doctors to do this now because they have a special form, a checklist that the doctor just has to complete. And I don't see, they should be very grateful for that because, you know, just to have a do not resuscitate order doesn't mean anything. You really need to have some indication of why that order is there. Now, let's go on to the thorny issues of nutrition and hydration and physician and euthanasia-assisted suicide. Much of my thinking here comes from the years that I've had dealing with dying patients. And they're 17 years now, and I've tried to figure out how many I've really been involved with, not necessarily sitting at each one's bedside, but being involved with the nurses who went out to see the patient and the team that made all the decisions concerning the patient and the families. And it's somewhere between 8, maybe 9,000. I don't know, that's a very rough figure, but that's quite a few people. And some of the things that I say now are going to be based on the experiences that I've had in hospice and that many other people have had in hospice. And one of the experiences, of course, is that with nutrition and hydration at the end of life, giving food and fluids to a patient who is dying. That's a difficult issue because in our society we equate the giving of food with caring and love, and when you don't do that any longer, people think somehow I'm not caring enough, I'm not loving. And we also feel somehow that starvation and dehydration are painful processes. In fact, I heard just a few years ago a doctor tell a patient, oh, that's the worst death that your mother could die. If she's not swallowing anymore, if you don't give her IVs and you don't put a tube down, that's the most painful, horrible death that anybody could have. Well, you know that's not true. When hospice came along and started taking care of patients in their homes and in the nursing home, we found it was not true. That the patients who did not have artificial nutrition and hydration were the ones that died much more peacefully. And that the giving of tiny amounts of food or small amounts of water was much more loving than hooking that patient up to a machine and giving them something that would cause them to have pneumonia, to swell up, and to have all kinds of horrible things happen to them. And was much easier for a family to love that patient, to embrace the patient, to show their concern than if they were constantly watching a machine that was beeping. And when you have artificial food and artificial food fluids going on, the attention is all on the machine. It's not on the patient. And we had a patient in a nursing home that was in a persistent vegetative state. The wife, I remember a few years ago, we had a big thing about it. Wife wanted to take him home away from the machines, so she said I could embrace him one last time. And we went through a lot to do that, but we did. And we had a hard time convincing everybody. Ruth, are you giving me a signal?
No, I'm really not, but you triggered something in me, and that is
okay.
Pohlen touched on ethno-geriatrics and some of the different cultures, and one of the things I know she hit was the role of food.
Right.
And how food is nurturing. And we often hear that at the time of death, where food is very important in certain cultures. And if somebody can help their mother by feeding them chicken soup, and it's nurturing,
right.
There's a role to that. And whatever that culture is, that can play an important...
A very important role. And it's difficult for families to understand that way of showing love is perhaps not appropriate here at the end of life when a patient is dying of end-stage lung cancer. And you have to take time to sit down with the family, and all the hospice people are involved in this, not just the nurse, but also the chaplain, the social worker, the physician, sometimes the volunteer, in helping the family understand that right now, when this is a body ravaged by disease, clearly at end-stage lung cancer, that putting food in that body is not going to benefit the body at all. It can't be used by the body, and not only will it not benefit, but it may cause great suffering. It might cause the person to vomit, it might cause them to choke, to develop a pneumonia. Giving an IV might cause a patient to swell from head to toe, which I've seen many, many times. Might produce more secretions from the stomach, might produce vomiting, might make this death so much more miserable. This is hard for a family to understand. It has to be spelled out for them 1, 2, 3. And to understand that at the end of a terminal illness, when a body can no longer use the food you put into it or the fluids you put into it, that the most peaceful way is to simply allow death to occur naturally. And you know, something else happens. It hasn't been studied enough. But nature, in its wisdom, will, in this process of starvation and dehydration, will let the body elaborate what we call endorphins, which is the body's own morphine, which has an analgesic effect to help in the control of pain and to make the whole process more peaceful. We have recently, I might say one more thing before talking about the recent. recently studies are appearing about what happens to the body when food and fluids are discontinued. And they have run careful laboratory studies now, and they find that the biochemistry is there's very little disarrangement. It isn't that all the chemistries just go at high levels. We have relatively normal glucose, relatively normal kidney function, there might be some changes there, relatively normal calcium, all of those things. And there isn't that great disturbance that one you'd expect from a laboratory picture whatsoever. But the most prominent symptom that patients who no longer eat or drink have is a dry mouth, which is often interpreted as thirst. But it has been shown that even small amounts of water or just moistening the lips will relieve that sensation. You don't need IVs to control that sensation of thirst, because the sensation arises from a dry mouth, which is often due to other factors. Might be due to the drugs the patient's getting, maybe to chemotherapy, maybe to X-ray therapy. The dry mouth can be due to a lot of things. The dry mouth is not necessarily associated with the dehydration, because they know if you fully hydrate that person, they still have the sensation of dry mouth. So the thing to do is to relieve the dry mouth with careful, meticulous mouth care every hour. Swabbing the mouth with, we have some solutions that can be used that give the feeling of moisture, keeping the lips from cracking. All of those things can produce the benefit to the patient that you want. It's the sensation is not going to be reversed by giving tons of fluids. It just isn't, and studies do bear that out. Now, most recently, several articles have appeared that I know are going to create a lot of discussion, and you have one of them. One of them is by Dr. Ira Byock on the conscious refusal of nutrition and hydration. Now, you know that years ago, eons ago, people, when we didn't have all this technology, felt they were dying, would simply walk out into the forest and die. Some cultures, I think this still happens. In India, in Benares, the town of death, there is a little hut where people go when they feel that they are dying. The person will go to that hut, and that's the hut where they don't do any feeding, no food or fluids, and with the family around, will go into a peaceful death. That has proved peaceful time again. It sounds like a strange concept to us because we're so used to seeing food and fluids as basic to life, and that you can never get rid of those. But when you consider that as death approaches, if we can make that a more peaceful, comfortable experience by whatever means, whether it's not eating or not drinking, we certainly are obligated to do that because of the fact that what we're controlling is not death itself, but the process of dying. We don't have any control over death. I don't believe in euthanasia or assisted suicide, but we do have control over the process of dying. And our chief aim is to make that process as comfortable and as peaceful as possible. If there is a person who consciously wishes to refuse food and fluids, and there are more of those people than you think, that person should certainly be allowed to do that. And that is not euthanasia, it is not assisted suicide. You are not assisting a suicide when you permit that. And that is no way euthanasia, because first of all, the conscious person has the right to refuse food and fluids at any time. At any time. That's the person's right. That's not creating one's death. That right is there, and when that right can be exercised. And incidentally, in some of our patients go to Dr. Kevorkian, they have that right. They could easily end their lives by not eating or drinking, and death would occur within 1 to 2 weeks. It depends on the fluids. If you still have a small amount of fluid, the patient will live longer. Most patients who stop food and fluids completely will die within a week to 10 days. That's guaranteed. So that 29-year-old who went to Dr. Kevorkian just a little while ago was suffering from end-stage Lou Gehrig's disease, ALS, certainly had the means to produce his own death. He didn't have to involve anybody else. He had the right to make that decision. He could have said, I'm tired of living, I just want to stop eating and drinking. Patients have that right. They don't need to go to Kevorkian. If they want to do that, they can do it, and they can do it legally and morally and ethically, in an ethical and a moral and a legally correct manner. Now, if a patient, one more thing. If a patient were obviously healthy and says, I don't want to eat or drink anymore, I think most religions would have a lot of trouble with that. I know the Catholic religion would, because there is an obligation to maintain one's health. However, if a patient is terminally ill, and the case is hopeless, they certainly have the right to refuse food and fluids.
I think that some people's concern is that as soon as they become unconscious, then somebody's going to call 911 and
Well,
get resuscitated.
Well, that's where they have to make their wishes known. Yeah, but you know, if this process is going along and a patient decides to do that, there was a beautiful example of that in JAMA. I wish I'd brought that reprint along, in which a doctor sat at the bedside of his mother, who consciously refused nutrition and hydration, called her family around her, was cheerful till the very end. The last day, could no longer speak, but family held her hand until she died very peacefully. This is a very natural way to die. It is within a person's ability to do. Nobody else needs to be involved, and you don't have the specter of all the things we deal with when we look at euthanasia and assisted suicide. So read Dr. Bayak's article. It is well done. Dr. Bayak is in the process of writing a book, and I think it'll be a bestseller. He's one of the members of the Academy of Hospice Physicians. I've known him a long time. He's up in Montana yet, but I don't know. He's probably going to be all over the world pretty soon. He's an extremely articulate man of deep thought, and he has given a lot to the whole hospice movement in his thinking. He's been chairman of our ethics committee. Now, I think it's 3 o'clock and I need to quit, but I want to just leave with you 3 points.
We're here till 3:30.
Oh, are we?
Something else you need to say.
No. Well,
Let him go a couple minutes.
no, it's such a beautiful day. I know everybody's just dying to get out there. I wish we could have had this class outside. Yeah. Let's, euthanasia and assisted suicide.
Bad looks over there.
What'd you say, Ruth?
I said I'm getting bad looks over there.
I have given talks on euthanasia and assisted suicide. I've given arguments for, arguments against, and have tried to, balance them and get dialogue going, and that it's been discussed in the community on several occasions, and with considerable emotion, as happened last year at the Chapman Graduate Center, if any of you were there. But in the years of dealing with dying patients, I've learned 3 big things, and they're really responsible for the attitude that I have toward these topics. And the first thing I learned was that pain and suffering can always be relieved. Always. Now, relieved. I didn't say completely eliminated, relieved. And I gave you one example of where pain or the suffering due to symptoms was relieved by a method that we don't use every day, by conscious sedation. But emotional and spiritual pain, too, can be relieved, as well as physical. So the second, I'll say them 3, and then I'll say a little bit about each one. Then I've learned that the end of life is often the most meaningful part of it. We've seen so many people die, and have seen how they have died, and that the end of their life is often the most meaningful part of their life. And then, the third point, how a person dies has a profound effect on their survivors. It's not just a dying person. How that person dies affects everybody around him. The family, the friends, the caregivers, everybody. And based on these three things, I have come to the conclusion that we certainly should not legalize anything like euthanasia or assisted suicide, because we're looking at the wrong solution to the problem. First place, we have excellent methods of pain control, as I told you earlier, excellent methods now. And pain, most pain in the patient who is terminally ill, 90% can be controlled by medicine given by mouth. You don't need intrusive devices, you don't need an epidural catheter, you don't need fancy things. 90% can be controlled by medicine given by mouth, safely and without addiction. Now that's a fact. And sometimes people need to tell their doctors that, because occasionally, as I heard the other day, I guess it's not funny, the man who sells the detail man for the morphine, MS Contin. You know, MS Contin is the sustained release form of morphine. And he was talking to this nurse of an anesthesiologist. And she was saying, well, the doctor never gives more than 30 milligrams of MS Contin. And those of you who have given it know that that's just, you know, very small dose. And he said, but you know, you can go up, because with morphine you can go up. There's no ceiling dose on morphine. You keep going up safely. And she said, but no. Then, if we gave more than 30 milligrams, there wouldn't be any need to to insert the epidural catheter. So, boy, that's that illumination, illumination. And that's what's out there. That's what's out there. And some people go right from Tylenol number 3, Tylenol with codeine, doesn't work. Let's put in an epidural catheter. Yes, sometimes epidurals are a good thing. When used selectively, we even use them in hospice now and then. Sometimes that is the method of choice, but very seldom. It depends. It depends a great deal on the case. And you never think of that right away. You start with the other things first. People who are dying seek to be free of the pain of dying and of the fear and the anguish of dying. And they need to feel that they have some control over their dying. I think, of course, that's what's behind euthanasia and assisted suicide, is this control issue. But people can control, and their method of dying can be controlled. Their death, not, but their method of dying, their process of dying can certainly be controlled. And people can have a great deal of control over that. As you saw just now when we talked about conscious refusal of nutrition and hydration, that's within everybody's control. So people don't realize that they have that much control. I think to some people that probably will be illuminating. I have here a statement. I don't know who said it, but I think it's a good one. Pain and suffering are part of the human condition. It's what we do with them that counts. So to eliminate pain and suffering by killing the patient is not a realistic, is not a valid method in my book. And that's the easy method. That's the easy way out. And you know, if we were to legalize it, it would be attractive to people, and even doctors, who wouldn't want to spend the time in dealing with a patient's pain and helping them through the suffering, the emotional and the spiritual suffering that they're having. And it would be so much easier then to go the Kevorkian route. Another reason why we should not legalize euthanasia and assisted suicide ever. You know, incidentally, many of the states are turning down the initiatives for that. You know, it passed in Oregon, of course, but it's on ice because they have a restraining order. And as I had here, there are a couple other states now in which the initiatives have failed. Assisted suicide, New Mexico, and see, what was the other state? Measures are also expected to fail in the remaining states where they were introduced: California, Connecticut, Maine, Massachusetts, Michigan, New York, Vermont, and Wisconsin. So I think people are taking a good long look at this and are having a lot of dialogue about it and perhaps arriving at the right conclusions. Now, number 2, I've learned that the end of life is often the most meaningful part of it. You know, some people die having missed the whole point of living. Some people just never get it all together. Some people get it all together just at the very end and suddenly realize what life is all about. And if that happens, even within a few days, that's worthwhile, because that's the fulfillment of a person's life. To find out who we are, that we're worthy as human beings, that we are connected to our brother, to our sister, that we're connected to a higher power. To find those things out and to really feel them inside can validate a person's life. And sometimes that only happens at the very end, under the pressure of impending death. It doesn't happen to everybody. Some people still, as I said, die having missed the whole point of living. But this can happen if we create a climate in which it can happen. You can't make it happen. But if you, by good care of the patient and good care of the family, you can facilitate this. Oh, we can certainly make death a peaceful, perhaps even a joyful experience, and not the bitter, anguished event that it sometimes is. Some people learn life's most important lessons only at the very end. Sometimes it's dramatic. In this man that I told you about, the lessons that he learned about the love of his family and the wisdom that he had to transmit were tremendous. It was hour by hour. Literally, he changed before our eyes. And it was everybody involved in hospice. And we recognized something great and spiritual coming out of him. The nurse, the social worker, the aide who came, everybody said, you know, there's something special about Jack. And as he grew at the end of life, he became a shining spirit. And that happened in the space of 10 days. So certainly the end of his life was the most meaningful part of it. I like those who've heard me speak, I'm always quoting Viktor Frankl, but Frankl wrote Man's Search for Meaning, which is that book that everybody, is required reading for the human race, Dr. Balfour Mount says. But Frankl says, one can rise above oneself, one can grow beyond oneself, literally up to one's last breath. And that's true. That's true. And we have seen it. We've seen it sitting at the bedside. Now, the third big lesson that I have learned, and many of us in hospice have learned, is that how a person dies has a profound effect on their survivors. People never forget how a person dies. If it's a bad, chaotic, distressing death, that memory stays with them all their lives and even affects their functioning, because they think back and, oh, I wish it hadn't been that way. And I wish we'd been able to do something about that. And some of their guilt is a result of those regrets and those wishes. But how a person dies affects everybody around them. And that perhaps is one of the most powerful arguments against assisted suicide and euthanasia, because those acts are not just the acts of an individual or between a doctor and a patient. They are acts of community. This is a social act. And we have had no studies yet, I haven't seen a thing published about what are the feelings of family of people who've gone to Dr. Kevorkian or have requested and received assisted suicide or euthanasia. What are their feelings? Nothing. Nothing has appeared in the literature. We do know that in people where a suicide has happened in the family, there can be tremendous psychological trauma, tremendous guilt, and tremendous grief that affects that whole family. So why couldn't we postulate that if a person has been involved in one of these decisions to go to Kevorkian and have himself killed, that that decision itself would affect that whole family lifelong? And their part in either making that decision, helping a person make it or just trying to dissuade them from it, that they would have enormous psychological trauma as a result of this sort of thinking. So looking at euthanasia and assisted suicide is not an individual act. It is a social act. It has profound implications for all of society and spreads way beyond that doctor-patient relationship. And I know the people who advocate this say, but this is a person's right. I have the right to kill myself. I have a right to be killed. Well, no, we do not have the right to kill ourselves. We do not have the right to be killed. And no one person has a right to ask anyone else to kill them. That right does not exist. We do not have that right. So when you're thinking about it and you're discussing it and dialoguing about it, and if it ever comes to an initiative in Texas, and it might, although right now everybody is so up in the air about managed care that euthanasia and assisted suicide have taken second place. You know, we don't have this other dialogue anymore. But these are the sort of things that hopefully will guide our thinking, you know, as we confront these issues. Now, I really think that I should stop speaking because you've all been a wonderful audience, but we need to come to some conclusion here. Do you have any questions or comments?